Hi, I'm Susan Elliott. I'm a nurse practitioner at St. Louis University School of Medicine. I work in the Division of Geriatric Medicine. The talk for today is suspected UTI in post-acute long-term care. Our university does receive funding through HRSA via a GWEP grant or the Geriatric Workforce Enhancement Program grant, and part of my salary is supplemented. AMDA, which is the American Medical Directors Association, convened in 2020 and reviewed the evidence of why UTIs are so highly prevalent in post-acute long-term care, and they created a consensus statement. Some of the important concepts here are listed, and lack of guideline awareness, high resident colonization, pressure from family to diagnose a possible UTI. I've personally run into this a lot. And then the lack of clear criteria on ordering testing were the big problems. We also found lack of knowledge in how to collect samples or interpret the results. There was a lot of overdiagnosis, misdiagnosis, poor antibiotic stewardship, which further spread resistant organisms, already a problem in this demographic. More than half the antibiotics prescribed for UTIs in post-acute long-term care are inappropriate. A lot of time was spent on looking at antibiotic treatment and what should be done. UTIs really should be addressed case by case and should no longer be categorized as simple versus complicated, because we all know we would prescribe a longer regimen, maybe a more in-depth regimen for a complicated case. And below here, you'll see that most UTIs, according to the evidence, are cured in less than 7 days, and that includes 82% of CAUTIs, which is the catheter-associated UTI. No difference was found among febrile or neurogenic bladder cases, whether they got a less than 7-day treatment, a 7 to 14-day treatment, or 14-day treatment. Men, however, did initially come up inferior in a less than 7-day treatment compared to 14 days for a short-term cure rate, but when the long-term cure rate was evaluated at 70 to 84 days, there was no significance. So the takeaway here is that most cases really should be treated with less than a 7-day treatment regimen of antibiotics. Some of the failure risks that might have a person be more at risk of not responding to treatment are listed here below. The urine retention, indwelling catheters, recent instrumentation, neurogenic bladder, diabetes, dialysis, immunosuppression. This may be the case, but it may not, as we saw on the previous slide. These factors are something a person should consider when looking at a treatment regimen. So what is asymptomatic bacteriuria? Well, it's colonization, not infection for the first, and it will present with a positive culture, so it makes it confusing. So the person will have greater than 100,000 potentially CFUs per milliliter and less than 2 species, but they don't have a systemic or local symptom, and that's the important part. Up to 50% of female residents and up to 40% of male residents in post-acute long-term care are colonized. So this is not a UTI. Altered mental status was excluded by the expert panel as a reason for testing, and that is because it's a result of delirium and it's not necessarily a UTI. It could come from any infection, and if we test because of altered mental status alone, we're likely going to find a positive culture because of the high prevalence of ASB. So the signs of delirium really should be associated with a systemic or a local urinary symptom to warrant testing. The UTI reporting guidelines, we're familiar with these. This is McGear's criteria and the CDC Healthcare Associated Surveillance Protocol for UTI in long-term care. They are not supposed to be used for evaluating a UTI, but that's what we find that we do. They really require completed testing in hand to do this. They're designed to validate the diagnosis after the fact, and really they're an epidemiology tool to look at whether or not the right treatment was provided. A quick refresher on McGear's criteria, because it's important to understand. It's a clean catch urine culture that comes back positive for greater than 100,000 CFUs per milliliter with less than 2 species. If you get it via a straight cath, the positive has to be positive for greater than 100 CFU per milliliter with any number of species. And then you have to satisfy one of the 3 situations here that are listed below. So you have to have acute pain, acute dysuria, or the acute testicular epididymis or prostate pain or swelling, fever or leukocytosis. And leukocytosis in this case has been recently lowered to 10 for the white count. And then you have to have at least 1 local symptom, or you can have no fever or elevated white count, but you have to have 2 or more local symptoms. So a person with a catheter, it's a little different. The culture had to be obtained through new tubing and a new catheter system, and it needs to be positive for greater than 100,000 and less than 2 species. And then they have to satisfy only one of the below. So they have to have a fever, rigors or chills, hypotension, which is defined as less than 90 systolic or a big drop from their baseline. Do they have purulent drainage around the catheter? Do they have flank pain or CVA tenderness? Do they have the acute testicular pain, swelling, or so number 7 is kind of confusing. They add in the acute confusion or a decrease in function, but the caveat is that there should be no alternative diagnosis and that they have to have the leukocytosis with it, again, greater than 10. So instead of using the reporting tools, we really need to be using the clinical decision tools. And one such tool was identified in the consensus statement as the AHRQ suspected UTI decision tool. And it is a 2-page SPAR format. It provides supporting information for later compliance when you have to do the reporting for the McGears. It's a checkbox style, it goes real quick, and when they tested it in 12 facilities, it did reduce antibiotic use by 30%. So what are SBARs, you might ask? They're evidence-based communication tools for collaborating. The S stands for situation, B for background, A for assessment, and R for recommendations. Now, R for recommendations really is coming from the person who's doing the assessment, which is the staff or nursing. So it sets the communication standard. SBARs are proven to decrease negative patient outcomes. They're part of our best quality practice measures in post-acute long-term care. And they really do promote nursing judgment through assessment and being a part of the interdisciplinary team. What are the barriers to using SBARs? Well, the biggest barrier is time. So anything that's cumbersome takes a lot of time to do in the context of having staff shortages post-pandemic or high nurse to resident ratios are just not going to get done. Also, skill is a big factor. Novices are less able to recognize clinical problems, interpret the changes, and make appropriate recommendations. So what we did here at SLU is we took the decision tool out of the AHRQ suspected UTI SBAR, and we incorporated it into our own. And we have a assessment for the initial assessment, and then we have a follow-up. So the follow-up is to report lab work or any changes in status, and move on with a regimen if one hadn't been prescribed previously. They're both checkbox style for ease and speed. We included pertinent background medical history, which was helpful for any provider that later needs to know those things. And then we included a focused urinary assessment, which really has to get done. So staff need to be able to know what questions to ask, and they need to be able to palpate and percuss and figure out if we have indications for testing. The recommendations are based on the nursing assessment in our SBARs rather than just a request for orders, and they incorporate the treatment options based on the failure risks, which include non-pharmacologic options. The follow-up SPAR provides ongoing assessment, which is missing in the original AHRQ version. So it's key information for later reporting, and it differentiates, ours does, ASB from UTI. So it includes an option to actually stop antibiotics had they been started previously. This is, I'll let you guys go ahead and pause on this slide and take a look at the two SBARs. This information is available on the Gateway Education Center website, and you can certainly email us and we'd be happy to send you PDF versions. But on the left, you'll see here, this is the initial assessment form. You'll see the decision tree there in the middle. The assessment is highlighted in yellow, and then the recommendations are very easy in checkbox style. On the right, you'll see that there's a little more information in the background. It includes whether or not the labs were received and what the current orders are. Again, the same assessment is there. And then if you look, the top box has whether or not it's ASB. And then you have whether or not it's a symptomatic UTI or a COTI. They have to satisfy one of the designated situations to qualify, so you know you're hitting on your criteria. And then again, the recommendations are pretty much the same, and then they have the option to stop the antibiotic. This is our protocol. This is hung in every nurse's station. So it starts with, do you suspect a UTI? And it puts people right into the mode of doing the assessment. And I find that nursing assessments are missing a lot of the time in post-acute long-term care. What you'll get is a phone call that says, family says this or patient says that, and no assessment was done to validate any of the reported items. So we start with the assessment. It moves on to which tool are you going to use, the initial or the follow-up SBAR. The red boxes you see here to go through the local symptoms, go through the COTI warning signs, whether or not a person might actually need an antibiotic empirically, and then how to contact the provider. So in summary, we did education on what the guidelines were. We convened all the nursing and did this, and then we went over the protocol itself. We went over the SBAR, how to perform the focused urinary assessment, which we'll go through a little here in a second, and then doing a teach back on what suprapubic palpation and CVA percussion is all about, and what are the non-pharmacologic and pharmacologic options that they can recommend and why. So what are their rationales? So we go through the treatment failure risks and whatnot. So the SBARs and the protocol cards were at every nurse's station, and then when they would send it, so we use actually a messaging system that's HIPAA compliant, and when they would ask for, hey, can we get a UA on this person, they had to have this SBAR filled out and scanned in. So that was part of the reason that we were successful in implementing this. It's real easy to get a call after hours or in the middle of the night, and then basically you just say, yes, you can have the UA. I don't care, just you can have it. So it does take a lot of work at reinforcing to the nurse every time that they need to fill it out. So hit a lot of resistance on the time factor, again, the big barrier to filling out SBARs. But if you're persistent, it can work. The teach back on CVA percussion is described here in case anyone wants to go through this with their staff. And it talks about what a positive result is. And then the teach back on what suprapubic palpation is and exactly where and how deep you're going to press and what a positive response is. We also went through educating the collection considerations, and this is most important because male residents, might have an obstructive uropathy, and that the likelihood of having trauma with that would be a problem, so that most men really need to have a clean catch sample after having good peri-care. And then we also discussed how female residents, their urethra being so close to the outside of their body really increases the chances of contamination. And especially if a person is obese or they're demented, considering the twice weekly showering schedules that go on in facilities, So these all play a part. So females really needed straight cathing using a sterile technique. And how, if we pick the wrong technique, that we often don't have time to wait for a second culture to come back before we have poor outcomes with the resident. So it's best to do it right the first time. And then we talked about the need for changing catheters on a person that has a chronic catheter. This is the pre-post test that we provided staff, and I'll let you go ahead and pause on this for a minute and complete the questions, and we'll move to the next slide here in a second that shows the answers. These are the answers, and they're highlighted in yellow. If anybody has any questions on the test, again, these materials are available at the Gateway Education Center. We're happy to share with everyone. So that is the end of my presentation. These are my references. And this is all updated evidence. So that's it. Thank you.